Okay guys, we have discussed about the asthma. Now let's discuss about the other obstructive lung diseases. The next obstructive lung disease that I am going to discuss now is bronchiectasis. Okay, bronchiectasis. Now in the name itself it's there, the bronchi. Okay, bronchi means the bronchi. Ectasia means what? Ectasia means dilation. See, even here you can very clearly see the bronchi are getting too much dilated. Okay, why the bronchi are getting dilated? Because they are dead. Now they are dying, the bronchi are dying. So that will lead to permanent pathological dilation of the bronchi. Now why they are dying? Might be because of infection. Why there is infection? Because of obstruction. Okay, why obstruction? Cystic fibrosis. Okay, I will discuss about that. Okay, I will discuss about the causes of this bronchiectasis. Now, what exactly is bronchiectasis? First, let me write here the definition. It's pathological, permanent dilation of bronchi and bronchioles. Bronchi and bronchioles are getting affected with necrosis and destruction. Okay, now they are totally dead and they are totally gone. Okay, necrosis and destruction. What are the causes? Why bronchiectasis? This is important. Causes. Number one cause might be congenital disorders. So some congenital disorders by birth itself, certain congenital disorders can lead to this bronchiectasis. Next, infections, acquired thing, especially with TB or foreign body obstruction or the airway obstruction. Okay, airway obstruction. So these are the causes of bronchiectasis. Now what are these congenital disorders? Which congenital disorders are going to cause this bronchiectasis? See the congenital disorders, let me write here, it's cystic fibrosis. And the second congenital disorder that can cause bronchiectasis is Cartagena syndrome. Okay, Cartagena syndrome. So now the next important point which I want you to know is regarding the cystic fibrosis and Cartagena syndrome. Okay, let me write here cystic fibrosis. So what exactly is happening in the cystic fibrosis? I said it is there from the birth itself. So it's a congenital disorder and familial that too. Okay, it's going to follow the autosomal recessive inheritance pattern. Okay, it's going to follow autosomal recessive type of inheritance pattern. Now what is the problem with the cystic fibrosis? Same, there is a gene called as CFTR. CFTR means what? Cystic fibrosis. Transmembrane regulator gene. Okay, cystic fibrosis transmembrane regulator gene. See, this gene is mutated. Okay, this gene is mutated. So because of the mutation of this gene, the CFTR channels are going to be defective. Sir, what are the CFTR channels? CFTR channels are chloride channels. What is the function of the CFTR channels? Let me tell you. See, look here. Imagine this is your bronchi. Okay, imagine this is your bronchi. Okay. So imagine this is your bronchi. Now in your bronchi, see I am showing you the epithelial cells over here. Okay, this is for easy understanding. Okay, so the epithelial lining is not going to be like this. It's a different type of epithelial lining, but you can understand. So imagine these are the epithelial cells which are lining your bronchi. Okay, see normally what happens when the CFTR gene is functioning? Okay, when the CFTR gene is functioning, what happens is, so these channels which I am drawing here, these are called as the CFTR channels or the chloride channels, they will also be functioning. Okay, they will also be functioning. So what they will do, what these channels are going to do, okay, let me draw the channel in a bigger way. Imagine this is the CFTR channel. So what this CFTR channel is going to do, this CFTR channel, it is going to pump the chloride out of the cells. It's going to pump the chloride out of the cells. So out of the cells in the sense, who is going to be there here? So this is the place where mucus is going to be there. See, imagine this is the place where mucus is there. Okay, so the chloride is being transported into the mucus. Now along with this Cl minus, okay, along with this Cl minus, even sodium goes into the mucus. Okay, sodium will also come into the mucus. Wherever sodium goes, water follows the sodium. Okay, so simply like this. First chloride will go, followed by sodium and water. Now in this condition, the cystic fibrosis, this gene is defective, CFTR gene is defective. So the chloride pumps are not going to be functional. When the chloride is not being actively transported into the mucus, the sodium movement and the water movement will not happen. So the what happened to the mucus, see, generally speaking, it's a logical thing, right? Wherever the ions go, water follows. First chloride will go. Okay, so whenever simply try to put it like this, wherever the chloride goes, water follows. Okay, now the chloride is not going, so water will also not go. When the water is not getting transported into the mucus, what happened to the mucus? The mucus will become thick. Okay, so there will be thick secretions in the respiratory tract. Not only the thick secretions in the respiratory tract, the thick secretions in the entire body. Okay, so the person who is suffering with cystic fibrosis, is going to have thick secretions in the respiratory tract, in the genitourinary tract, in the GIT, gastrointestinal tract. The secretions are going to be thick because of one problem. What is that problem? It's a CFTR gene mutation, cystic fibrosis transmembrane regulator gene mutation. The chloride channels are not going to be functional. When the chloride channels are not functional, the problem is going to be thick secretions. Okay, thick secretions. So what happens, sir, if these thick secretions? What happens? Okay, the secretions are thick. Now, if the secretions are thick, do you think these secretions can be easily cleared away by the cilia? Can the cilia easily clear these thick secretions? No, definitely not. So cilia becomes immobile. Now the cilia becomes immobile. They cannot properly able to beat and they cannot properly able to clear the mucus. So what happens? With the time the mucus will start to accumulate and causes the total obstruction. The mucus is not getting cleared away. So that's going to cause obstruction. Okay. So what happens, sir? Okay, obstruction. So whenever there is obstruction, remember, wherever there is obstruction, distal to the obstruction, imagine this is the bronchiole, this is starting and this is ending. Now this is the proximal, this is the this is the proximal part and this is the distal part. Now if there is obstruction here, always the distal to obstruction, infections will automatically happen. That's a basic rule. Okay, so what happens is this obstruction will lead to infections. Okay, obstruction will lead to infection. So this is a question asked. Obstruction is going to lead to infection or infection will lead to obstructions? Now you have only seen 50% of the story. Okay, okay sir, obstruction can lead to infection, but not only that's true. Infection like TB or some other infection, these infections will also produce lots and lots of mucus. Okay, in infective conditions there will be lot of production of the mucus. So this infection can also lead to obstruction. Okay, so it can be any way too. Obstruction can lead to infection or infection lead to obstruction. At the end of the day, what happened? So because of this obstruction, there is obstruction. At the end of the day, finally there is obstruction. Because of this obstruction and infection, okay, obstruction is there as well as infection is also there. Okay, both of them are going to be there. So this will cause inflammation, and during that inflammation, it's a severe inflammation, chronic inflammation leading to necrosis of the cells. So it's going to cause a necrotizing inflammation. So necrosis, the bronchi are gone, bronchioles are gone. So necrosis, that's going to cause bronchiectasis. That's what's going to cause the bronchiectasis. Next, what are the complications? See, the clinical features and complications. The clinical features you can simply understand. What are the clinical features that are going to be seen in this condition? What do you think? So what are the clinical features? So the patient is having infection. So definitely fever is going to be there. And infection, necrotizing infection is there. So that's going to cause purulent sputum, purulent sputum production, and especially these patients are going to have cough during, okay, with the rise in the morning, okay, during rise in the morning, they are going to have cough, morning cough, okay. See, it's an infection that is happening, right? Because of the obstruction, there is infection. So this infection is the one which is going to cause abscess, localized infection in the lungs, lung abscess. So the complications are the lung parenchyma. It's going to be complications. What are the complications? Lung abscess. And it's a chronic inflammation. It's a chronic inflammation. See, any chronic inflammatory condition, it's going to cause amyloidosis. Now, the reason why I am specifically telling here is because later on we are going to study about something called as a chronic bronchitis. The name itself is there, chronic bronchitis. But chronic bronchitis doesn't increases the risk. Okay, chronic bronchitis doesn't increases the risk of amyloidosis. So generally speaking, all chronic inflammations can lead to amyloidosis, but not chronic bronchitis. Again, I am going to discuss there in the topic of chronic bronchitis. So what are the complications? One complication is lung abscess. The second complication is going to be amyloidosis. Is there any risk of lung cancer? Okay, those persons who are suffering with this bronchiectasis, is there any risk of lung cancer? No, there is no risk. No risk of lung carcinoma. So these are some important risk factors and complications. Now, one thing I have explained you here. So what is that? Cystic fibrosis, autosomal recessive disorder where there is a chloride channel defect. Here I want to add a few more important points, 2-3 important points which were previously asked in the exams, though they are not directly related to the pathology, but I still want you to know them. Okay. So cystic fibrosis patients, they not only suffer with the lung problems, bronchiectasis. Apart from lung problem, what else can be seen? See, they are going to be thick secretions. I have said you the person is going to have the thick secretions. So the secretions are going to be very much super saturated, super thick. So what these secretions will do? They will block the pancreatic ducts. Okay. So if this is the pancreas, head of the pancreas, this is the pancreas. You know there is a pancreatic duct. Okay. Now in the pancreas, what will produce? Digestive enzymes. Okay. Pancreas is going to produce digestive enzymes. In which form? In inactive form. So what are the examples of those inactive enzymes, zymogens? The examples are trypsinogen, chemotrypsinogen. Okay, trypsinogen, chemotrypsinogen, ogen. So if anything is ending with the word ogen, it is inactive in nature. Now what happens in this condition is the ducts are getting blocked. Okay, the pancreatic ducts are getting blocked because the secretions are very thick. The secretions, while they are going through this pancreatic ducts, they will simply obstruct the thing because they are not liquefied properly. They are super saturated, super thick. So now what happens? There is a block. Now what happens? Sir, now this trypsinogen, chemotrypsinogen, they are supposed to be getting activated in the duodenum. They are supposed to be getting activated in the duodenum, where the trypsinogen is going to be converted into trypsin with the help of enzyme called as enterokinase or entropeptidase. But now in this condition, what happens is the trypsinogen is getting activated here in the pancreas, and the chemotrypsinogen is also going to get activated in the pancreas. Now what these enzymes will do is, first they will damage the pancreas, first they will start to digest the pancreas. So this is called as autodigestion of the pancreas. okay, autodigestion of the pancreas. So that's going to cause chronic pancreatitis. That's going to cause a chronic pancreatitis. So these patients who are suffering with the cystic fibrosis, CFTR gene mutation, because of the CFTR gene mutation, thick secretions in the lung is going to cause the obstruction followed by infections leading to necrotizing inflammation of the bronchi and bronchioles leading to bronchiectasis. And not only that, the CFTR gene mutation, same thick secretions in the pancreas is going to block the pancreatic duct, where the inactive enzymes of the pancreas are going to get activated in the pancreas, leading to autodigestion of the pancreas, leading to chronic pancreatitis. Okay, these are some important points. GIT related problem is chronic pancreatitis, lung related problem is bronchiectasis. Apart from this, what else you should know regarding cystic fibrosis? Anything else? Let me write here. Just a few points are there. In cystic fibrosis, patients, especially males, they are going to have absence. In many cases, it's noted that there is absence of vas deferens. Okay, there is absence of the vas deferens. What exactly is the vas deferens? The duct which takes the sperms. Okay, there is absence of the vas deferens. Anything else? See, normally in the body, in the viscera, the chloride is being pumped. Okay, the chloride is being pumped into the secretions. Okay, the chloride is getting pumped into the secretions. It's getting sent into the secretions. But at the level of skin, in the sweat glands, something different happens. The chloride will be taken into the cells. Okay, into the cells. Normally, exactly opposite. Okay, same gene, same channels, everything same. In the body, the chloride is getting sent into the secretions, but in the skin, at the level of skin, the chloride is being taken from the secretion into the cell, working exactly in opposite way. So in cystic fibrosis patients, imagine there is this baby with the cystic fibrosis. Now the CFTR gene is working? No. CFTR channels are working? No. At the level of skin, the chloride is being reabsorbed? No, the chloride is not getting reabsorbed. So as the chloride is not getting reabsorbed from the secretion, that is the sweat, the chloride is not properly getting reabsorbed. See, chloride, it's a salt, right? Chloride is a salt. The salts are not getting reabsorbed out of the sweat. Now the mother takes this baby, and whenever the mother kisses the baby, the mother is going to feel salt. Okay, salty taste from the baby. Okay, so these babies are called as, okay, salty babies. So what you should know, at the level of skin, okay, at the level of skin, what happens? Normal. What is normal? Chloride is reabsorbed. From where? From sweat. Now what happens in cystic fibrosis? Chloride is not reabsorbed. Okay, chloride is not reabsorbed. As the chloride is not getting reabsorbed, the chloride levels in sweat increases. So how the baby is going to be? The baby is going to taste salt. So these babies are called as salty babies. Okay, salty babies. This is the MCQ. Salty babies, grey babies, blue babies. Many things will come in your exam. Salty babies seen in cystic fibrosis. Now what is the treatment? So this treatment is also very important MCQ. What is the treatment for the cystic fibrosis? There is a drug called as ivacaftor. Okay, there is a drug called as ivacaftor. This drug, what it will do is, it will make the chloride channel functional again. It will make the chloride channel functional again. So ivacaftor is a drug that can be used in the treatment of cystic fibrosis. Okay, so done. Once cystic fibrosis is completed. Now I have explained you what are the causes of bronchiectasis. The cause of the bronchiectasis is congenital disorder, cystic fibrosis. Completed. Now one more disorder is there, which is called as a Carter-Jenner syndrome. Okay, Carter-Jenner syndrome. So how this Carter-Jenner syndrome is going to contribute to the obstruction? After obstruction, automatically infection will start. Okay, so now let me tell you a few points about the Carter-Jenner syndrome. What's the problem, sir? Carter-Jenner syndrome. So what is the problem with this syndrome, Carter-Jenner syndrome? See, it's an example of this Carter-Jenner syndrome is an example of primary ciliary dyskinesia. Okay, primary ciliary dyskinesia. So what exactly is this word primary ciliary dyskinesia is telling you? Primary ciliary dyskinesia means primarily, mainly there is problem in the cilia beating. Dyskinesia, the cilia are not beating properly. Dyskinesia. Okay, in the cystic fibrosis there is no problem with the cilia. The problem is with the mucus, thick secretions. Here the problem is with the cilia, sir. Primary ciliary dyskinesia. Cilia are not beating properly. Okay, why? Why the cilia are not beating properly? Okay, why the cilia are not beating properly? Because there is a protein in the cilia and flagella which is called as dynein. So there is a protein called as a dynein. This is defective. So normally this dynein, where it is present? It is present in cilia and flagella. Okay, cilia and flagella. So the dynein, it's a protein which is present in the cilia and flagella. It helps in the beating of the cilia and flagella. Now the dynein is not present. Now if dynein is not there, do you think cilia is going to beat? No, the cilia is not going to beat and the flagella is not going to beat. So when the cilia is not beating, do you think whatever the mucus that is getting produced in the respiratory tract is going to be properly cleared away? Definitely not. The mucus is not going to be properly cleared away. The mucociliary excalatory phenomena, the mucociliary clearing is not going to happen properly. When the mucociliary excalatory phenomena, when it is not happening properly, the mucus is going to start accumulating inside the bronchus. With the days, the mucus will start to accumulate and that's going to cause obstruction. You know, after the obstruction, definitely there is going to be infection, right? So, defective dynein lead to ciliary, like you know, the immobile cilia become immobile. Okay, cilia become immobile, so that will cause defect in mucociliary excalatory. Okay, excalatory function. Okay, mucociliary excalatory phenomenon is going to be defective. Because of this, the mucus will start to accumulate. Okay, there is going to be mucus accumulation. So because of this mucus accumulation, there is going to be obstruction. That will lead to infection, and you know, from infection, necrotizing inflammation leading to bronchiectasis. Completed. Now, what are the important points that you should know regarding the Cartagena syndrome? See, these Cartagena people, they are going to have a triad of symptoms. If the person is suffering with the Cartagena syndrome, he is going to have a triad of features. 3 features are going to be there. What are they? Number one, you know, it's the lung problem. Okay, accumulation, like you know, the mucus accumulation leading to infection, inflammation. So one is bronchiectasis. See, mucus is not only getting produced in the respiratory tract, but the mucus is also getting produced in the sinuses, in the paranasal sinuses also. So this mucus, whatever is getting produced in the paranasal sinuses, is not getting properly cleared away. As it's not getting properly cleared away, there also infection will start, inflammation will start. So leading to sinusitis. Okay, leading to sinusitis. The patient is going to have the chronic sinusitis, bronchiectasis, and very important thing is, since cilia is not only important for the clearing the mucus, but the cilia is also important for the movement of the organs during embryogenesis. During embryogenesis, the organs which are produced, for example, the heart is produced more towards the left side, more towards the right side. Okay, the heart is there, the heart is formed more towards the right side. But because of the ciliary beating, the heart is surrounded by the cilia. Because of the ciliary beating, the apex of the heart is moved towards the left. Okay, thanks to the cilia. But in this Cartagena syndrome, the cilia are not beating by birth itself. So there will be opposite placement of the body organs. The heart which was supposed to be on the left side, it will be on the right side. So this is called as situs inversus. Situs inversus. Example is what? Example is the dextrocardia. Okay, so dextrocardia, sir, means right side of the heart. And apart from this, what else can be there in this Cartagena syndrome? What else, sir? What else you should know? What do you think? So there will be male infertility. These are the triad of symptoms. Okay, bronchiectasis, sinusitis, situs inversus, dextrocardia. These are the triad symptoms. Apart from this triad, the patient is also going to have infertility. So why infertility? Now sperms have to beat, sperms have to go and they have to fertilize the ovum, right? They have to go and fertilize the ovum. So sperms are having what? Flagella. Sperms are having flagella. So now the sperms are not going to go properly. The immotile sperms, the sperms are also not going to go properly because the dynein is also a component of the flagella. So that's going to cause infertility. Okay, infertility. So these are the symptoms which can be seen in a patient who is having cartaginous syndrome. The point is, at the end of the day, the cartaginous syndrome and the cystic fibrosis, these two conditions are going to cause an obstructive lung disease which is called as bronchiectasis. Okay, bronchiectasis, obstruction is going to be there. After obstruction, like infection is going to cause total destruction of the bronchi. Bronchi are totally gone. They are totally necrosed. They are just the empty spaces. So permanent dilation, pathological dilation. So with this, bronchiectasis is also completed. In the next video, we will be discussing about the emphysema and chronic bronchitis, the COPDs. We will be discussing the third part. Hope the video is helpful. Thank you.